Perfect. And take two. Okay. Are you advancing the slides or am I?
I will. You can just maybe introduce yourself a little bit, just a tiny sec, and then I will advance them. You just say next.
Okay. Again, this is prostate cancer consideration for gay men, and my name is Max Hamlyn. So we did, if anyone has joined late, we did sort of go over what the prostate gland is, and that it is a muscular walnut-sized gland that sits above the bladder and in front of the rectum. So you could advance. Perfect. It plays an important part in both sexual function as well as urinary function, especially when it is enlarged. It can affect the flow of urine. Okay, next, please. If I talk too fast, please let me know. I'm a newfie, so we have a tendency to talk a little faster than normal. Testing is one of the areas. So it involves taking a blood test, and if they are looking for prostate specific antigen in the blood, and depending on the level of this antigen, it can mean that there is cancer present or not, and it is the PSA is produced by the prostate. Usually they'll try and do a digital exam at the same time, but there are a number of things that can affect the PSA being elevated other than cancer. There can be an infection in the prostate. There can be inflammation of the prostate gland. There can also be what they call saddle. Next slide, please. Saddle injuries, which is common among cyclists, that they can have a elevated PSA, and also some cyclists will complain of numbness in the perineal area because of the pressure on the nerves as well as on the prostate. Enlargement of the prostate, or sometimes called benign prostatic hypertrophy, and sexual activity before having the test done. So it is important for receptive members of the community to avoid having any anal sex for at least 48 hours before the test, and that would include masturbation as well, because that can give a false positive. Studies have showed that gay, bisexual, and in particular Black, gay, and bisexual men are screened for prostate cancer at a much lower rate than heterosexual men. Some of the reasons for this is due to the health disparities faced by gay, lesbian, bisexual, transgender, and questioning LGBTQ people. Health disparities affect people of color no matter what sex they are. Next, please. So, how does prostate cancer differ from gay men and heterosexual men? So most males, when you show up at a urologist's office, are considered heterosexual unless you divulge your sexual orientation. Gay men seldom declare their sexual orientation due to the stigma that we have faced over the centuries, and that is something that heterosexual men have never had to do. They don't have to identify themselves. Prostate cancer in gay men is greatly understudied versus heterosexual men, as sexual orientation is not part of any of the cancer surveillance questionnaires. In 2015, a literature search of prostate neoplasm or prostate cancer yielded 100,000 papers or peer-reviewed publications compared to 30 peer-reviewed publications when they added sexual orientation to the search. There is also less education available for gay, bisexual men versus heterosexual men. Gay men often feel isolated as they do not have the same support system as in a traditional family versus what heterosexual men do. Next, please. Gay men also face unique challenges in as the loss of the prostate, or the site of pleasure in receptive anal sex, and the ability to ejaculate, which is very important in gay sex as the visual and the emotional aspect. They also experience rectal irritation or pain sufficient to prevent receptive anal sex. Erections can be too weak for insertive anal sex. Anal sex actually requires an estimated 33% more rigidity than vaginal sex. The stigma from prostate cancer and its sexual side effects can often lead some gay men to feel that they are less attractive or desirable to their partners. This is something that we went over a great deal in the course that Holly and I took. Another difference between gay men and heterosexual men is a greater number of bisexual and gay men have a more flexible relationship. These can be monogamous partnerships to relationships that permit other than one partner. Also, sexual behaviors of men who have sex with men varies greatly than that of heterosexual men. Heterosexual men do not lose their sexual identity when they have their prostate removed. However, gay men who identify as tops or bottoms will lose their identity due to no longer being able to fulfill the role which they identify as. And this isn't like switching off a switch. You can't just change, nor is it easy to do. A lot of gay men who are in the community, that's how they're identified in the gay community, is as a top or a bottom. Gay men it is sometimes the only way that they identify themselves in the gay community, like I said, as a top or a bottom. Next, please. Okay. Talking to your physicians or your care team. It's very important to be open and honest with your care team. You want to make sure that you receive the best possible care that you're entitled to, and telling your doctor and team can be telling them they can tailor your care needs and the best support that they can get you for you. You also want to discuss what's important to you and how your treatment will impact you, your relationship, as well as your sex life. If they are assuming, that you are heterosexual, then you need to tell them, you need to really advocate for yourself. I've been in situations where I was in hospital, my partner was with me, and they came in and I got and who is this? And I just said, this is my husband. Is there an issue? So unless you sort of stand up and advocate for yourself, you can sometimes be stigmatized or dismissed. Your concerns can be dismissed. If your partner's husband, or they ask you, what does your wife do? Just say, well, my husband or my partner works at wherever. If they're with you, like I said, you just say who they are and is there a problem. It does catch people off guard when you sort of stand up and say, hang on here. It also, you have the right to have unstigmatized care. Everybody is entitled to proper care. Being gay or straight doesn't matter. You can request another care team or a physician. I was lucky that the physicians I had during my initial diagnosis and my surgeries knew that I was gay, and I had worked with some of them when they were residents in urology, and I was a nurse in the OR. This goes for all members of your care team. Excuse me. Never be ashamed of being who you are or who you love. That's the big thing. It's your life. Next, please. Some of the treatment options. So there are quite a number of them. Active surveillance is one. This is where they basically just monitor you, do a PSA level every 3 months, 6 months, depending on what your initial level is. No treatments are done during this period. Basically, they're watching to see if there's any growth of the cancer. You might consider this if it's localized, it's small, it's slow growing, and there aren't any signs or symptoms of any cancer issues. There's no spread or anything like that. There are several different ways of treating it. Active surveillance was one. We want to discuss these ways of treatment options when you meet with your urologist the first time, and you want to know what's involved in this treatment and how is it going to affect your quality of life post-treatment, post-surgery, post-radiation. You want to know those facts going into this, because sometimes it can determine which one you want to do versus what you don't want to do. Radical prostatectomy is the actual surgical removal of the prostate gland, the seminal vesicles, and the vas deferens. So the seminal vessels sit behind the prostate, and the vas deferens is the tube that runs from the testicles up through the prostate into the urethra. And this can be done as an open procedure where they do a small or an incision just from the belly button down towards your pelvic bone, just at the bone at your pelvis. And they can also do it laparoscopically with the assistance of a robot, or we have one in Ottawa. It's called the Da Vinci robot, and the surgeon operates it through a small screen. There are different portions to the surgical removal. So one is called the nerve sparing, and this is where the nerves and the blood vessels that feed or are around the prostate itself. If you consider a walnut, it would be on the outside of the walnut would be the vessels and the nerves, and those are responsible for erections and the blood flow. They can be, they're not removed, they can be touched or tugged on depending on a retractor. They try their best, but what's in an anatomy book as to where blood vessels and nerves are is not exactly the same with everybody. They can be a little centimeter or two difference. So this can cause decreased sensation for a period of time. And a limited lymph node dissection is also done at the same time, and that's to check to make sure that there hasn't been, even though the cancer can be contained to the prostate, they still will do a lymph node biopsy just to ensure nothing has gone outside of the prostate itself. I had, as Holly had mentioned, I had bladder cancer, and part of the treatment was surgical removal of the prostate at the same time. And they did a lymph node dissection at that time, both around the bladder and around the prostate. So that's standard for open procedure or laparoscopic procedure. So there's also radiation treatment that they do for prostate cancer. And there are two types of radiation treatment. One is called external beam therapy, where they're using a high energy X-ray that is directed a beam towards the prostate. Is this conducted over several days, 2 weeks? Neighbor of mine just went through 36 radiation treatments for his prostate cancer. It does, and it can include urinary obstruction, because if you remember the slide of the prostate, the urethra goes right through that to the bladder. So if they're radiating the prostate to kill the cancer cells, they're also irritating the urethra. And when we have an irritation, it causes usually swelling, and therefore the opening of the urethra shrinks, and it can cause an obstruction. Because it's also in front of the bowel or the rectum, it can cause the radiation is going through your body, so it will go through the bowel tissue as well, and you can get some loose stools with some mucus being passed for several weeks to months afterwards. And there's a lot of fatigue associated with radiation, whether it's to the prostate, the lungs, or anywhere in the body. It's a side effect of radiation. Brachytherapy is where they actually insert radioactive seeds into the prostate gland to kill the cancer. These seeds give off a high to low amount of radiation, and it can cause localized skin irritation and some diarrhea after insertion. When I worked on urology, we knew whoever had radiation seeds in, we had to work behind either a lead apron or a lead screen because of the radiation being given off. Next, please. So androgen deprivation therapy, or ADT, is a hormone therapy which is medication to reduce the level of male hormones or androgens in the body to prevent it from fueling the cancer cells. So the cancer cells in the prostate, because it's part of a sex organ, thrives on testosterone. Or the other androgen is dihydrotestosterone. So androgens are produced by the testicles, but there's other parts of the body that produce a small amount, and that's the adrenal glands that sit on top of the kidneys, and the prostate itself can produce some, as well as the cancer cells can throw off some of the androgens. Orchidectomy is another way, which is the surgical removal of the testicles. Therefore, you're removing the source of the testosterone. The amount produced by the adrenal glands and other organs is very minimal. And there's also medical castration, where they actually give medication that will stop and inhibit the production of testosterone by the testicles. So some of the side effects to all of this is radiation. The external beam does cause long-term rectal bleeding, fibrosis, as well as irritation of the bowel. It can cause burns to the bowel, and thus it causing a lot of diarrhea. And these symptoms can be very discomfort and to receptive men. Radiation does cause erectile dysfunction, but it's over a gradual period of time that the erectile dysfunction happens, versus with a surgical removal, which is almost instantaneously within it. Usually that day, erectile dysfunction happens. Brachytherapy. You have to abstain from sexual intercourse for at least 6 months after brachytherapy, because of the fact that it is radiation, and it can cause radiation injuries to your partner's penis. So therefore, they recommend at least 6 months to prevent that. The other thing that's not recommended after any type of radiation, either brachytherapy or external beam, no fisting. If you're into fisting, it's not recommended post-radiation. And to take several months to a year before the use of a dildo, enemas, or any other insertive devices to prevent any tearing or puncturing of the bowel. Again, the radiation goes right through the body, so it can make the bowel is already very thin and easily punctured. So when it's had radiation, it's very friable. It's like onion skin. It's very see-through. Surgery. So like I mentioned, it's immediate after the prostate is removed. It can it can last up to 2 to 3 years or longer, depending on how quickly those nerves start to respond. It will resolve over time. You'll start to notice that you may have a bit of chubbing or some nocturnal erections. That's an indication that things are starting to uh, improve. You'll still have sensation. It's just that you won't um, be able to get an erection right away. And it, like I said, it will gradually get firmer. It might not be at the same strength you had before you had surgery, but it does improve as time goes on. Incontinence because of the prostate removal. So at the bladder junction to the prostate urethra, there's a valve basically, and at the other end there's a valve. And when you remove the prostate, those valves, sometimes you lose those with the surgical removal. So that causes the incontinence because the urine is able to flow out. So Kegel exercises, if anyone is going to be going for prostatectomy, it's highly recommended that they start doing the Kegel exercises before they have the prostate surgery done. This is something that I started to do, knowing that I was going in for the surgery. I started doing it before surgery, and afterwards I thought I can do this, and my uro-oncologist asked me if I wanted a referral to a pelvic floor physiotherapist, and I did do that, and I recommend it to anybody who's going to have a prostatectomy, is to have that, do the Kegels and ask for a referral after surgery, because they do help and they can give you tips on how to do it correct. I thought I was doing it correctly, and then I went and saw them and they said, yeah, you're doing them right, but this is a better way of doing it, and it made a big difference. Using an incontinence pad is appropriate. It's just because, like I said, it's leakage, and it's the Tenna is the pad that I use, and they have a number of different products. And I still wear a pad just on that because I had my bladder removed, and I had a new bladder or a neo bladder, which is they take 2 feet of your bowel and they make a bladder out of it. So I have no receptors like you do in a normal bladder, where you start to feel you've got urine in there and you get the sign, oh, I should pee. I have none of that. So sometimes it's like, uh-oh. So having a pad is just a safeguard, and it does help. Okay, next please. Radiation. So short-term effects is increase in urinary urgency. So you get that sensation you got to go, and you have to go now. It's not like, oh, I'll wait. It's, you will wet yourself if you don't sort of go. And that's frequent during treatment because of the irritation. And that the way that the radiation beam is sort of hitting the bottom of the bladder, So it will also trigger that urgency. Some urinary discomfort, burning sensation, because again, like I said, the radiation is irritating the urethra, and the urine is a harsh substance. It can burn. If you've ever had a UTI or a urinary tract infection and you get that burning sensation, that's what it would feel like during the short term of the radiation treatment. And it's not uncommon to see a little bit of blood again from the irritation, as well as some in your stool, which both will resolve. But again, it's from the radiation and the irritation to the tissues that are being irradiated. Also, fatigue, like I mentioned, is very common during radiation, whether it's anywhere in your body. Fatigue, it's accumulative, is the best way to describe it. As you go through radiation, the fatigue increases each day. And then as you get away from, once your treatment is over, the fatigue does dissipate, and you'll start to feel you're getting a little bit more energy. Best thing to do is rest, because by the time you finish your radiation, you'll probably feel like you've been run over by several Mack trucks, because that's how tired you'll feel. Skin irritation is very common during radiation. And there are creams and ointments that the radiation oncologists or the radiation technicians can recommend to help ease that. I think sometimes they're using CeraVe, which is a moisturizer, as well as Flamazine in some cases, depending if it's a radiation burn or the irritation, the skin starts to flake off. Like I said, temporary sexual changes, decreased libido, erectile dysfunction will gradually start to get worse as the treatment goes on. And over time, again, it will start to return to normal. Long-term effects. So urinary incontinence, again, doing Kegel exercises helps with that, because you're increasing the strength of the pelvic floor muscles, and by squeezing your muscles, you can control the flow of the urine. And also wearing an incontinence pad. Sexual dysfunction or erectile dysfunction. There are medications, Viagra, Cialis, as well as there's a injectable medication that you can be prescribed, that you inject right into the penis, and you will get an erection from it due to the medication, but it's localized to the shaft of the penis. They will, if I didn't mention it, if you have a prostatectomy, they will order Viagra or Cialis post-operatively, and it's to keep the blood flow to the surgical area. It doesn't give you an erection or any side effect like that, but it's just to keep the blood flowing to that area post-operatively. You can get the inflammation of the rectal lining. You want to make sure you are proper bowel care. The biggest thing is to avoid constipation. If people say, oh, take Metamucil, Metamucil is really good if you're having diarrhea and the mucus. You can take a teaspoon of that in some water, and it helps to lessen the diarrhea and the mucus. But afterwards, if they say, oh, take lots of Metamucil, you have to be drinking 8 to 10 glasses of water, or it turns into concrete. And you don't want to have anything causing irritation to the lining of the bowel or to cause a tear, because then you're into a whole different ballgame. Bowel obstruction is common, again, because of the irritation from the radiation. So again, maintaining a proper bowel care, maintaining good nutrition, good fiber intake, and monitor your bowel for any changes in pattern. If you're starting to see that you're going towards constipation, make sure that you're taking something. There's PEG, there's Laxaday medication like that, just to make sure things are moving. You don't want to go any more than 2 to 3 days without having a good bowel movement. So the ADT, or androgen, so a side effect of this is hot flashes. And this is, as Holly had mentioned, I'm a palliative care nurse. So pain and symptom management is a big part of palliative care. It's not all about end of life. It's about making people comfortable. And this is the big thing I hear from my prostate cancer patients, is the hot flashes. So we recommend, or I recommend, taking some apple cider vinegar. That helps to regulate the hot flashes. Also, you can put a little bit on a J cloth and put it on your forehead or the back of your neck, and it really cools you down. Speak to your wife, your mom, your older sisters, and ask them for some helpful tips. Like 1 minute I'm sure if you have females in your family and they're going through menopause, 1 minute they're opening all the windows and the next minute they're turning up the heat. So men go through the exact same functionality of the hot flashes. Big thing is a lot of men will complain about their nipples being very sensitive or very tender, is to try and wear a muscle shirt, and that will sort of keep them snug to your body, and you're not going to get that rubbing on your, if you wear a shirt or undershirt, because they do complain of the tenderness. Gynecomastia is growth of the male breast. I don't know how to describe it. It's just more like fatty tissue into the male breast tissue, and it'll look like you have small breast versus pecs. Mood swings, very common, especially if you're receiving estrogen injections every 3 months, where they insert the cylinders under your skin into the fat. That's estrogen, so your estrogen levels in your body go up, and you become a lot of more emotional, more high triggered, very much mood swings. Weight gain is very common, so you're wanting to monitor your weight. You want to monitor that you're eating healthy to try and avoid gaining too much weight. Osteoporosis is also a side effect of the ADT. So you can request a bone density to be done early on, and then calcium and vitamin D3 help to lessen the side effects, and you can ask your oncologist or urologist about having this ordered for you. Some of the other effects of the ADT is muscle mass, decreased muscle mass. A lot of people think they're losing weight when it's actually they're losing the muscle mass itself. So your arms will look a little thinner, your legs will look thinner. You may be the same weight, but you will look like you've lost weight. So what are we up to now? So prior to, I think we went over this one, did we not? Oh, sexual health. Yes, sexual health. So prior to the surgery, you're wanting to discuss with your care team, your urologist, about the effects of the treatment will have on your sex life. If possible, ensure your partner is present during the discussions. That's a big thing, is the communication. Inquire about the use of medication, Viagra, Cialis, and like I said, it is ordered after surgery. You can, if things start to improve or you start to get some return of erectile function, you can ask to be ordered some Cialis or Viagra just to help promote the erection. Inquire about the use of vacuum pumps or cock rings, visiting a sex shop or a website that sells sex toys is very beneficial. It'll give you great ideas for spicing up your sex life. We have a store here in Ottawa called Adult Fun Store. It has a wide variety of every type of kink or desire you'd want. Don't be hard on yourself regarding the erectile dysfunction. It's treatment, part of the treatment of, side effect of the treatment of the prostate cancer. It will take a while to return. Like I said, it can be up to 2 to 3 years. Some people get return a lot quicker. Some other people, it takes up to 3 years for it to return, or sometimes it can be a little longer. You won't have the same firmness you did you won't have the same firmness as you did before surgery. So it just takes some time for things to return, but going knowing that it's not going to be the same hardness as you had before surgery, post-operatively. You can have a great orgasm without an erection. It may take a little trial and error, but you will reach one. It is, if you think sort of back to when you were pubescent and you had orgasms, it's sort of similar to that, but it can take time. You can still masturbate even if you're not erect. You will still get the same sensations through your body. You can't ejaculate, but you still have the body orgasm. Okay. There is great sexual intimacy without having penetrative sex. On a personal note, I've noticed that I enjoy sex a lot more with my husband now versus the, okay, let's have sex, you have sex, your orgasm, okay, that's it, let's go on with our day. This is more intimate. It's more, you become more in tune with your body, what you like, what your partner likes, versus, reaching that orgasmic sex. This is a lot more intimate and much more satisfying, I find, and it's longer. It takes you take your time, you relax, you enjoy your body, you enjoy the touch, you enjoy the sensations of the body. Incontinence is an undesirable side effect, but like I said, there are products out there to help. What's the term? I can't remember it now, but sometimes if you're concerned, you can, when you have, your body has that orgasm, full body orgasm, you can leak urine. So if you're into your oral sex, it might be best to wear a condom so that you don't leak a little bit of urine into your partner's mouth. Okay. Like I said, request information on Kegel exercises and pelvic floor physiotherapists. Always have good communication with your partner. It involves both of you. You need to talk and understand what's happening, what's going to change. It's a journey of two, not for one. And I speak from personal experience. My husband was with me when I got my diagnosis. He wasn't with me when they did the cystoscopy and found the tumor and the cancer in situ. I had 2 different cancers in my bladder, but he was with me when I got the test results back and when I spoke to the uro-oncologist. And when I had surgery, it was during COVID, so he couldn't come and visit or anything. But when I went back to see urology or anybody, it was still during COVID, so I could only go by myself. So I thought of I was doing what was best for both of us without actually having talked to him and realizing that, you know what, it didn't matter as long as I was, cancer free and healthy, then that was all that mattered to him. And it made me realize that, like, especially doing the course on sexual counseling, that you have to talk to your partner and they should be involved as much as possible. Um, the side effects of prostate cancer can take a toll on your mental health. So if you need to talk to someone, ask for a consult to a counselor or a sexual health professional. It's very beneficial. So some of the resources that are out there is the Canadian Cancer Society, Prostate Cancer Canada, the BC Cancer Agency, because you guys are in BC. I did put in, and I had sent Holly this information on, Ottawa has a gay men's health clinic that just opened in November of last year, and their website has a lot of information about gay sex and gay health issues for gay men. Movember is a great website as well. They have a lot of information on prostate cancer, testicular cancer, men's health in general. Our course was actually sponsored by Movember on sexual counseling. And I did put down the Island Prostate Center as well, because Holly is a great source of knowledge on this topic. And these are all the my references. Some of these were really good detailed information. I found the Northwestern Medical Prostate probably one of the better brochures that I've seen. It's directed towards gay men than any of the other ones, and it was just released in 2003. Their Google search will bring you up all kinds of information. Mayo Clinic is a really good one as well. The American Cancer Society on hormone treatment, if you're looking at going that route. Next slide, please. And the National Association of Proton Therapy and Brachytherapy is a really good source of information if you're having brachytherapy done. These are all great references, but there are a couple that really stuck in my mind about if you're wanting to understand how things are affecting or going to affect you post-operatively or post-radiation treatment, or in general, how it will affect you. And that, gentlemen, and ladies, is my presentation.